easy, but a way to learn it.
Hello everyone, welcome to my YouTube channel. Today I came with a topic to discuss with you. COPD or chronic obstructive pulmonary disease. COPD is a disease characterized by airflow limitation that is not fully reversible. So if it came once, the effects will never leave the patient. It is chronic and progressive lung disease that makes it hard to breathe due to airflow obstruction. And COPD is a disease caused by chronic bronchitis and emphysema. Here is a diagrammatic representation of COPD-affected lung and alveoli. The normal and healthy alveoli have a structure and it maintains its elasticity due to a key protein named elastin. When there is an inflammation, the inflammatory cells release enzymes like elastase whose break down elastin, thus alveoli loses its elasticity. Let's see the definitions of COPD. First definition says, COPD is a group of lung diseases that cause airflow blockage and breathing problems. It is characterized by persistent inflammation and damage to the airways and lung tissues. COPD encompasses conditions like chronic bronchitis and emphysema. The second definition is more easy to understand and remember. COPD is a chronic and progressive lung disease caused by chronic bronchitis and emphysema resulting in airflow obstruction and breathing problems. Shall we see what causes COPD? Based on the first etiological factor, it is clear that smoking plays a major role in COPD. Prolonged inhalation of air pollution, chemical fumes and dust can cause COPD and other serious lung issues. The hereditary factor which can cause COPD is the deficiency of alpha antitrypsin, which is a protein made by the liver, inhibits an enzyme called neutrophil elastase which can damage alveolar walls. So the deficiency of alpha antitrypsin can cause damage to alveolar walls. COPD can also be caused by infectious agents which are streptococcus, pneumonia, Haemophilus influenza. I hope you understand what is COPD and the etiological factors of COPD. We can move to risk factors of COPD. As we discussed earlier, along with chronic bronchitis and emphysema, other chronic respiratory infections are also a risk factor for COPD. Genetic defect underlying the deficiency of alpha antitrypsin, which we already told. Smoking and long-term living in polluted areas can lead to COPD and other respiratory problems. A person who has a family history of COPD can also have a chance to get it. As we already discussed, COPD encompasses conditions like chronic bronchitis and emphysema. Let's learn more about them. First, chronic bronchitis. Chronic bronchitis is a disease where persistent production of cough and sputum present for at least 3 months in 2 consecutive years. As we know, the inhalation of irritative factors can cause inflammation. If this inflammation persists for 3 months or more than 2, lead to some changes, which is increase in number of goblet cells and increase in number and size of submucous glands in the large bronchi, which leads to increased mucus production. Along with this, as an irritant factor impairs the ciliary function, mucus clearance also stops. As a result of all these actions, obstruction in the bronchioles increases. Thus persistent airway obstruction leads to COPD. Let's look into emphysema. Emphysema is a disorder in which gas exchange impaired results from destruction of the walls of overdistended alveoli. As we explained earlier, inflammation causes alveoli to lose its elasticity and become distended. As a result, the gas exchange impaired. There are 3 main types of emphysema. Centrilobar emphysema, which affects the upper lung region, pantobular emphysema, which affects both bronchioles and alveoli, paraseptal emphysema affects lower lobes. Can we move to the clinical manifestations of COPD? Dyspnea, wheezing, chest tightness. The first 3 symptoms are caused due to the obstructions and inflammations. Do you know how edema in ankles happens in COPD? Due to low oxygen inhalation, it leads to hypoxia, which leads to pulmonary vasoconstriction, which later pressures pulmonary artery. Thus the pressure in pulmonary artery cause the right side of the heart works harder to pump blood into lungs. Eventually right ventricle weakness and fails. Leads to fluid backup in the body. This results in peripheral edema. Another symptom of COPD is chronic and productive cough, due to exposure to irritant. Cyanosis around lips is the result of lack of oxygen supply to tissues. Clubbing of fingers is due to hypoxia. Other symptoms are decreased exercise tolerance and barrel chest. To those who don't know about the barrel chest, let me explain. The barrel chest is an underlying symptom of COPD, rounded, bulged, outward and expanded chest due to air trapping in lungs. As the alveoli lose its elasticity, it can't fully exhale, so some air remains in the lungs. Gradually adapts and becomes a barrel-shaped chest. The pathophysiology of COPD is easy to understand. Due to exposure to irritant factor, leads to inflammation of the airway epithelium, which causes infiltration. This can result in either bronchial irritation or breakdown in lung elastic muscle, which leads to chronic bronchitis and emphysema. Leads to airway obstruction, which is a classic symptom of COPD. May I explain how to identify COPD in a patient? As in every hospital setting, first we take history collection and physical examination of the patient. The next one is A, B, G analysis or arterial blood gas. It helps to know gas exchange status, respiratory acidosis, carbon dioxide retention. Chest X-ray and CT scan helps to visualize the inflammation of lungs. Spirometry helps to examine lung function. Pulmonary function tests is a group of non-invasive tests which examines lung volumes, air flow, gas exchange efficiency, respiratory muscle strength. Echocardiogram helps to check pulmonary hypertension. Now we know what COPD, its etiology, clinical symptoms, pathophysiology, diagnostic evaluation. Let us go through the management of COPD. What are the goals we need to focus while treating a COPD patient? First priority always to improve ventilation, then to promote their health maintenance. After making sure the ventilation and health has been maintained, we need to prevent complications regarding COPD or any other related complications. Then to improve the quality of their life, as we know in COPD the effects remains within the patient even after a successful treatment. Facilitating removal of bronchial congestions will also reduce dyspnea, pulmonary congestions. So as to implement the goals, what are the management required? Let's see. In medical management, we provide bronchodilators like salbutamol, tiotropium to dilate the congested bronchioles, corticosteroid inhalation to reduce inflammation, vaccination for flu and pneumonia if prescribed. The surgical management of COPD includes bulectomy and lung volume reduction surgery. Let me explain each of them. Bulectomy is a surgical procedure in which large air-filled spaces in the lungs called bullae are removed. Lung volume reduction surgery is the removal of portion of disease having lung parenchyma. This type of surgery does not cure disease, but it helps to decrease dyspnea, improve lung function and to improve quality. Other management of COPD or pulmonary rehabilitation, oxygen therapy and smoking cessation. Pulmonary rehabilitation will help to improve breathing, physical strength, quality of life, emotional well-being through exercise, education, nutrition and counseling. Oxygen therapy will be given if prescribed. It reduces hypoxia and related signs. As we know, smoking is a major reason for COPD, so ceasing the use of it can reduce the progression of COPD. I believe you understand the management of COPD. Shall we move to nursing diagnosis and management? Nursing management always aims to reduce patient discomfort and improve health. First, we shall go through nursing diagnosis. 1. Ineffective airway clearance related to obstruction of airway and increased mucus production. This focus on ventilation. 2. Ineffective breathing patterns related to shortness of breath and coughing. This is to reduce dyspnea and also to clear ventilation. 3. Imbalanced nutrition less than body requirements related to anorexia and sputum production. This is to enhance health maintenance. 4. Disturbed sleeping pattern related to cough, dyspnea and restlessness. 5. Impaired gas exchange related to ventilation to perfusion inadequately. So as we discovered the problem, shall we go through the management as a nurse? 1. Encourage the patient for slow and deep breathing exercise. 2. Monitor respiratory and oxygenation status to assess the need for artificial ventilation. 3. Provide high protein, high caloric and nutritious food and drinks that can provide adequate calories. 4. Administer supplemental oxygen as ordered. 5. Instruct the patient for smoking cessation. 6. Chest physiotherapy with postural drainage if indicated. 7. Administer bronchodilators and aerosol treatment to facilitate clearance of retained secretions and increase ease breathing. Do you know what the complications are in COPD? 1. Respiratory failure, if it is not treated promptly. 2. Pneumonia due increased mucus creation and obstruction. 3. Atelectasis due to damaged alveoli. 4. Pneumothorax due to air trapping and congestion. 5. Pulmonary hypertension due to pulmonary vasoconstriction and artery pressure. Thank you guys for listening to me so far. I hope you guys understand this topic. If you have any queries, let me know through comments. We will meet in another video. Please support me and subscribe, like and share.